هسه موجودة مو هيك؟
دكتورة موجودة بس مو فول سكرين.
أنا يمي فول سكرين. هسه خلي تجيكم. أخاف تحتاج وقت.
دكتورة هو بالبرنامج هذا مال جوجل ميت ما تطلع الفول سكرين عندنا، وما بعد يعني سلايدات ما تتقلب.
زين هسه راح اقلب سلايد وشوف لي اياه. هسه انقلب؟
لا دكتورة ماكو.
بعده مو؟
اي دكتورة بعد على اول سلايد.
هسه
اي دكتورة هسه قام يلا.
Today we talk about radial intestine and large intestine. As you know, endoscopy we cannot use in the small intestine because it is long and tortuous nature. So the barium follow through it is considered as standard examination. We need 100 ml of the barium and then imaging at the interval until the barium will reaching the colon. It will take about 2 to 3 hours for the examination, and sometimes it is less or more variable according to the case. And also we have other imaging modalities similar to the barium follow through, but called enteroclysis, and in this we require intubation. That are, we inject the barium directly to the bowel through the tubes rather than swallowing. This it is give more detail and more information. Indication of the barium follow through in cases of an inflammatory bowel disease. It has structure, malabsorption, enterocutaneous fistula, post-bowel resection for the length and the short bowel syndrome, and in cases of the malrotation. It is called barium follow through for the small intestine. The most of the cases related to the small intestine we usually diagnose by CT scan rather than by barium follow through according to the situation. Sonography or just water by examination. It is detect thickening of the bowel wall as inflammatory bowel disease, lymphoma, TB, and other disease. Detect fatty stranding, detect masses, detect the complication of the disease related to the small intestine, and we can check all surrounding the bowel loop. Picture of the CT scan, axial and coronal. You look for this bowel filled with contrast material, easily visualized by study, and also these small bowel filled with contrast. We use gastrography. By MRI also can be used, but it is a not routine examination. A lot of things, and because of the peristalsis, it is of the limited use. Fistula, abscess, disease related to the Crohn disease, complication of the Crohn disease, and look for this bowel wall thickening by MRI. Ultrasound also have role, as you know, in cases of the appendicitis. The ascites related to the small bowel can diagnose by ultrasound. In cases of the intussusception, also we can reach the information by ultrasound. So we can use barium follow through, enteroclysis, CT scan, MRI, and ultrasound. Now we talk about the normal appearance of the small bowel by barium. Central and involving from the start of the jejunal region to the down to the pelvis. This is a small bowel. Continuous colon would be 25 millimeter and less. Contrast lie between the transverse fold, which it is called volvular conventins. The thickness of the fold itself, this is the fold itself, not more than 2 to 3 millimeter. Similar to the appearance of this tree, it is called volvular conventins, feathery appearance, and the appearance of this, it is more prominent in jejunum and less prominent in ileum. Less more prominent in the jejunum and less prominent in the ileum. This is a normal barium follow-through. Now we talk about the imaging finding in cases of the small bowel disease, which including dilatation, mucosal abnormality, narrowing, ulceration, fistula, and malabsorption. Some of the features similar to what we talk about the esophagus and gastric region, but there are other cases in case of the malrotation related to the small bowel. Dilatation. As I mentioned previously, the diameter of the small bowel should be 25 millimeter and less. If it is exceeding 30 millimeter, 30 millimeter considered are dilated. The causes of the dilatation are a lot, including malabsorption, obstruction, paralytic ileus, and pre-stenotic dilatation, according to the cause. The small intestinal obstruction. For this CT, dilated small bowel loop, air fluid levels, axial section, and if we check the diameter more than 3 millimeter fluid level by CT. Mucosal abnormality related to the small bowel. It may be thick. If you look for this fold, it occurs in cases of the malabsorption, in cases of the hemorrhage, edema to the bowel, inflammatory bowel disease, infiltration by tumor, and it is considered non-specific sign. Could occur with the increased thickness of the mucosal fold, but it is not specific sign. If you look for this by CT scan, thickening of the mucosal fold with the abnormal enhancement of this vulvoconventins associated with the bowel wall thickening. This is the lumen, and there's increased wall thickness of this bowel. Increased wall thickness and abnormal mucosal pattern are also detected by ultrasound, thick hypoechoic wall, and by MRI also there is an increased thickening of the wall with narrow lumen. This is part of the terminal ileum lumen and increased wall thickness. Another sign which is called narrowing or structure of the small bowel. In cases of the peristalsis should be transient and smooth, while permanent structure could be occur in the Crohn's disease, in tuberculosis, lymphoma, and also when there is a dilatation approximately. If you look for this segment of the bowel, it is so narrowed segment. Long segment of the bowel with narrow segment are narrow. By CT also can be detected. If you look for this segment of the bowel, this is the bowel, and this is the narrow segment. This is a narrowed segment, and there is a mass, so dilatation segment, a narrow segment, and also by MRI can detect narrow segment. Another sign of the bowel disease, small bowel disease, is the ulceration. Ulcer appear as spikes projection outward, which may be shallow or deep. If you look for these tiny spikes arising from the this is called ulceration. The ulceration may cause by Crohn's disease, by TB, lymphoma. Fine ulceration with the mucosal edema, it is called cobblestone appearance, and we will talk about it later on in the Crohn's disease. Look for this segment. There is a spike related to the ulcer. There is a spike here also related to the ulceration, and the spikes here related to the ulceration. The Crohn's disease, it is an inflammatory disease of non-specific etiology, also, non-specific granulomatous inflammation, nearly always affecting terminal ileum. So it has a predilection for the terminal ileum. Affected areas with the intervening normal areas So one of the characteristics of the Crohn's disease is its skip lesion. We have normal and abnormal area. Imaging finding are there's a structure, cecal contractions as a result of the adhesions, ulcers, dilatation, fistula, and mucosal thickening and distortion, in addition to the bowel loop separation by an inflammatory process. Picture previously, this is it called syringe sign. syringe so narrow segment، يعني مثل الخيط اللي رفيع كلش بحيث يبين ده ينقطع. إذا شوف هذا syringe so narrow segment of the terminal ileum, it is called syringe sign. This is one sign of diagnostic of the Crohn's disease. Narrow as a result of the spasm, edema, fibrosis produced by Crohn's disease. And also we have cecal contraction. This is the cecum and this is the terminal ileum of normal texture to the cecum, and at the region of the ileocecal valve, it is called cecal contraction. Ulceration, as I told you previously, fine ulcer and mucosal edema produce cobblestone appearance. There is a fine ulceration, spikes of the ulcer. This is produce cobblestone appearance اللي هو الموجود بالأرصفة. Transverse and longitudinal fissure ulcer with the intervening edematous mucosa. This is directly by inspecting of the small bowel and the mucosal edema, and the appearance of this by, if you look for this segment, cobblestone appearance, filling defect as a result of the spikes, and large narrowed segment of the bowel associated with ulceration and cobblestone appearance. Separation of the bowel as a result of the thickening of the wall and sometimes masses. If you look for this, there is a large mass related to the inflammatory process, and patient by this MRI, it is have a collection abscess with multi-fistula to the nearby bowel loops. This is a collection, and this is the site of the fistula, other connection with this site, and also even this is a CT, multiple fistula, and this is a central collection. By ultrasound also we can detect Crohn's disease, but it is not specific by ultrasound. If you look for this increased wall thickness of the segment of the bowel and hypoechoic, increased thickness of the wall by CT. By MRI we can detect the perianal fistula. This is the site of the fistula, and this is the site of the fistula. There is inflammatory process surrounding the inner rectal region with the air. It is a dilatation proximal to the narrow segment. This is a narrowed segment with the proximal dilatation of the bowel loop. Later on indicating sign of the malabsorption in the Crohn's disease. By MRI, this is a large segment of the small bowel with the narrow lumen as a result of the increased wall thickness. And this is also the segment with the narrowed wall and narrow lumen. This is related to the Crohn's disease. Also, another case related to the small bowel indicating bowel ischemia. Intestinal infarction, it is considered a life-threatening condition as a result of the occlusion of the superior mesenteric artery, whatever the cause. The finding usually it is thickening and edema of the wall. This is a lumen, and this is the wall. All of the wall is increased wall thickness. Also, the presence of the gas within the wall. Perforation may occur, and we detect intraperitoneal air. If you look for this, it is containing contrast and air. But if you look for the wall, there is a air in the wall itself rather than lumen. This is indicating small bowel wall. Tuberculosis may produce findings similar to the Crohn's disease. It's commonly involving the ileocecal region rather than terminal ileum. Diffuse peritoneal involvement can occur. We can detect ascites, thickening of the omentum, peritoneal and serosal nodule as a result of the TB. Lymphadenopathy also may be visualized. If you look for this segment of the small bowel, so thickened wall with the neurolumen, severely thickened wall producing complete obstruction to the lumen and producing mass-like lesion, similar to this lesion. Involve the small bowel also, and the finding may be similar to the Crohn's disease, similar to the TB. Small bowel defect by the nodules, displacement of the small bowel by the lymphomatous mass and by mesenteric lymph node. CT indicating marked thickening of the bowel wall, mesenteric and para-aortic lymph node, and we can detect deposit in other organ in the abdomen. If you look for this thickening of the mucosal fold and by CT severely thickened wall with the narrowed lumen, so that all of these findings are non-specific for disease, but according to the history and the clinical examination, laboratory investigation, we can reach to the final diagnosis. Have malrotation. Malrotation, if you look for this, the small bowel located to the right side, located to the left side, as a result of the volvulus. The malabsorption usually diagnosed finally by biopsy, jejunal biopsy. The finding could be thickening of the mucosal fold, if you look for this, diluted by excessive fluid, or it is less than because it is dilating and there is no absorption. Using of the barium flow through for demonstrating the structural abnormality that related to the malabsorption. Of the malabsorption by jejunal biopsy, but sometimes we do barium follow through for detection of the some causes that related to this abnormality, including Crohn's disease, lymphoma that causing malabsorption. Anatomical abnormality related to the resection of the part of the small bowel lead to the malabsorption. About small bowel obstruction, one of the most important topic. The causes peritoneal adhesion, which is by far it is the most common cause as a result of the previous surgery or inflammation, as sometimes the patient come to you without history of any inflammation or surgery, or he didn't know about previous inflammation, may be related to the hiatus hernial orifice, Crohn's disease, site of the volvulus, metastatic carcinoma, lymphoma, and the primary tumor of the small bowel. Anal obstruction usually diagnosed clinically. In other cases, can be done with water-soluble contrast material, and contrast should be seen within the small bowel in 24 hours. If the delayed visualization of the small bowel more than 24 hours, that means the patient may need surgery. So the role of the imaging in intestinal obstruction, this is the important point. It is differentiated through between mechanical and the ileus, number one. Site of the obstruction. Identify the underlying causes, complication as a result of the ischemia and perforation, and assess the viability of the bowel segment. So sometimes the patient come to you, the finding of the intestinal obstruction, and the doctor diagnose the patient that have intestinal obstruction. Clinically, I have, and it is a true diagnosis. But the role of the imaging included differentiated mechanical from the ileus, localize the site of the obstruction, identify the causes of the obstruction, assessment of the complication, and assess the viability of the obstructed segment. Also mention and take in your mind, this is the rule of the simple aid memory to memorize about the normal bowel, small bowel less than 3 cm diameter, large bowel less than 6 cm, appendix less than 10 millimeter, and the cecum should be less than 9 cm. This plain film, we have multiple, usually dilated bowel loops, air fluid level located in the central part. We have dilated bowel loops. This is the transverse colon. Normal follow through. If you look for this, obviously dilated bowel loops. In CT scan, we can show the site of the obstruction from dilated to the collapsed part, confirmation the presence of the mass. No imaging modality direct diagnose the adhesion modality. So this is a dilated bowel loop, multiple fluid level, and we have a narrow segment from here, collapsed bowel segment. This coronal and axial section of the CT scan. And this is a collapsed segment of the bowel. This is the transitional point between normal and abnormal segment of the small bowel. This segment of the small bowel, and this is dilated bowel, proximal dilated loop, and this is the collapsed segment of the bowel. This is the site of the obstruction. If you look for this abdominal and the lower pelvis, if you look, there is a hernia. This is may produce sign. شو وقت نشوف الهرنيا هذول؟ من اللي يجينا يعني نتوقع انه عنده مشكلة intestinal obstruction as a cause of the hernia؟ ايش تتوقعون منو راح يكون؟ تسمعوني؟
نعم دكتورة.
اللي يجينا نتوقع عندنا هيرنيا. دول الاولد ايج بيشنت عادة مرات يكونوا عندهم سيفير inguinal hernia, big large inguinal hernia، بس هي يعني انت ما تشوفها بالابدومينال. من تيجي تسأله إذا عنده هيستوري مال هيرنيا راح يطلع لارج inguinal hernia، وهي هاي اللي مسوية intestinal obstruction. يعني بدون ما هو ينطيك كل لازم تقعد إلى من ضمن history of inguinal hernia ممكن الobstruction umbilical hernia. This is one causes of the intestinal obstruction. Manifestation, previously we saw it as a result of scariasis or manifestations, roundworm, intestinal obstruction. If you look, longitudinal filling defect traversing the small bowel, this is tram-like like inside the bowel. You have any question here? Now we talk about large bowel. The imaging modality, first of all, it is colonoscopy. It is the best. We can do a colonoscopy. It is called gold standard, direct inspection of the mucosa, diagnostic and therapeutic. And also by this we can resection of the small mucosal lesion. Biopsy can be taken and reach final diagnosis. If we cannot do colonoscopy, so the imaging by CT scan and MRI, nuclear CT, you have to type pneumocolon and virtual colonoscopy. Barium enema need preparation to empty the bowel, to remove the material that's masking or stimulating the polyps by air to cover the mucosa, filming in the various time and various position to imaging the whole part of the bowel. If barium of the colonoscopy can be not done, we can, in cases of the incomplete visualization, impossible structure cannot pass through the colonoscopy, patient intolerance And in cases of the risk of the perforation, we cannot do colonoscopy. This is a normal appearance of the colon by barium enema. This is the rostra. This is the normal diameter of the bowel. If you look at it, the rostra more prominent in the proximal part of the colon and less prominent in the distal part of the. By CT scan, this is the large bowel, thin wall, materials. Importance of the CT scan is detection of the lesion itself, detection the site of the obstruction, and detect any abnormality in the surrounding structure and even far away from the lesion. Disease of the large bowel including structure, also dilatation, similar to the small bowel, filling defect, ulceration, and diverticular. If you look for this segment of the narrowing, this is the narrow segment in the descending colon. There's a pathology. The causes of the narrowing are a lot, including carcinoma, diverticular disease, ischemic colitis, TB, and a lot of the causes. And the narrowing occur anywhere in the colon. This is a large segment of the bowel with narrow segment. If you look for this narrow segment, this is a shouldering sign of the carcinoma, and this is the part of the bowel also the shouldering carcinoma. It is not a smooth narrowing. While in this case, there is a smooth narrowing of the bowel, and it is opened after stenting. Sometimes the narrowing occurs as a result of the compression from the outside rather than bowel wall disease itself. Segment of the bowel, descending bowel with the narrow lumen and thickening wall, and the importance of the cross-sectional imaging, detection of the site of the lesion, detection the length of the segment, the causes also, detection of the secondary to the nearby tissue, final diagnosis by this. Ulceration, if you look for, this is the type of the aphthous ulceration, tiny, large number of the ulcers, colon, it is called aphthous ulceration. Usually this is the typical finding of ulcerative colitis. Dilatation also may occur in the large bowel proximal to the obstruction, severely dilated segment of the bowel. This is cross-section, and dilated bowel. Filling defect as a result of the intraluminal lesion or the lesion related to the wall. If you look for a large filling defect, indicating polyp. Now we talk about ulcerative colitis. It is also of unknown etiology. Inflammation and ulceration always involving the rectum, and sometimes the process involving the whole colon. The cardinal sign is widespread ulceration. It is shallow or maybe deep. Other sign, loss of the rostra, edema of the rectal tissue, so increased space between the rectum and the sacrum. But the most important finding is the ulceration. This is a normal mucosa of the bowel. If you look for this superficial ulceration, the whole this segment, and also there is more prominent ulceration of the bowel. This is associated with ulceration and inflammatory pseudopolyp later on. Narrowing and shortening of the colon as a result of the ulcerative colitis may give rise to the rigid colon. It is a rigid tube. Pseudopolyp also may be formed in advanced cases. Effect projected to the lumen caused by swollen mucosa because of the ulceration. Structure also may occur in the ulcerative colitis. Whole colonic involvement and terminal end may also dilated produce incompetent ileocecal valve. This colon, it is featureless colon. This is called rigid, indicating ulcerative colitis. This is the segment, descending colon with irregular mucosa, thickening, and thickening of the wall with the narrowed lumen. Patient may have pseudopolyp as a result of the advanced cases of the ulcerative colitis. If you look for, there are large number of the multiple filling defect inside the bowel, and this is the bowel with air, so that there is multiple masses protruded from the wall indicating polyp. After ulceration, featureless colon, starched and narrow segment. One complication of the ulcerative colitis is toxic megacolon, usually diagnosed clinically, and we can use native study CT rather than with contrast. Barium and CT pneumocolon, because there is a risk of the perforation, endoscopy is contraindicated. If you look for this, thick wall, bowel wall, abnormal enhancement of the wall. Crohn's disease also can affecting the large bowel. Usually it has a predilection for the terminal area, but Crohn's disease also can affecting the large bowel. So the finding could be loss of the ulceration, narrowing of the lumen, shallow ulceration, and cobblestone appearance. Later on, deep ulceration, it is called rose thorn ulcer, abscess and fistula formation. It is a produced ulcer similar to this appearance of this هاي الأشواك اللي موجودة هنا. It is called rose thorn ulceration if you look for this large long spikes as a result of ulceration. Structure can be occur. Skip lesions also can occur in the large bowel if you look for this cobblestone appearance, but in the large bowel rather than small bowel. Diverticular disease also can involve the large bowel. It is a sac-like outportion of the mucosa through the muscular layer. It is commonly seen in the sigmoidal region. Diverticular can be seen with the barium. It is vertical outportion with the narrow neck to the sort of appearance due to the hypertrophy of the muscle coat. Maybe super added by diverticulitis. If you look for this, there are large number of the outpouching filled with barium. Diverticular disease. This is also diverticular. Diverticular can be diagnosed also by CT. First of all, there's a thickening of the wall of the bowel, and there's outpouching from the wall material filled with contrast material. So by CT can detect complication, thick bowel wall, pericolonic fatty stranding due to the perforation, detect fistula, sometimes detect peritonitis, peritoneal air and structure as a result of the inflammation. Now we have short note about the appendicitis. We start by sometimes it is diagnosed clinically, and we have a lot of the sign. You must know it, but radiographically we have multiple imaging finding can diagnose by ultrasound and by CT. Appendicitis is an inflammation of the vermiform appendix. It is the same. It is a common condition diagnosed by ultrasound and CT. The finding by ultrasound is a peristaltic, non-compressible, dilated appendix more than 6 millimeters. A beer rounded with the compression is applied. May be hyperechoic appendicolis with the posterior acoustic shadowing. Direct appendiceal wall. If the appendiceal wall layer detected, this indicated non-appendix. If the wall of the appendix layer not identified separately, it is indicating gangrenous stage of the appendicitis. And another finding in the appendicitis is the echogenic prominence surrounding fat, target appearance of the appendix in axial section, may found periappendiceal fluid collection, may be found also reactive lymph node, increased flow by color Doppler ultrasound apart from gangrenous type. So dilated non-compressible segment of the bowel of the appendix, target appearance in axial section, increased echogenicity of the fat surrounding the appendix. We can detect fluid collection, can detect lymph nodes surrounding the appendix and cecum. We can, by the color Doppler, increase vascularity. Segment of the segment, this is a hyperechoic structure with the acoustic shadowing, indicating appendicolis, and there is inflammation of the appendix with the collections, appendix. Ischemic colitis indicating acute infarction, which it is rare. The finding of the edema and hemorrhage. By barium multiple smooth indentation of the lumen, it produces the characteristic appearance of the thumb printing. Fracture may occur with the smooth tapered end, usually involving the splenic and sigmoidal part of the colon. If you look for this picture of the barium, it is produced طبعة الأصفر. This is indicating ischemic colitis. If you look for this severely thickened wall, enhancing mucosa, indicating ischemic colitis. Nematosis coli, the gas filled the space within the wall, diagnosed by plain film, and sometimes diagnosed by CT. If you look for this finding, there is a wall air. Volvulus, it is a torsion of the bowel around the mesentery. Torsion results in a narrowing of the lumen at the point of the rotation and compromising the vessel that supplies this short gut. More in sigmoid colon, which it is 60%, less in the cecum. So the dilatation proximal to the site of the twisting, diagnosing by plain film and CT, which is a wire sign. If you look for this sigmoid is similar to the coffee bean appearance by plain film. This is by barium study. We have peak appearance at the site of the twisting. If you look for this severely narrowed twisted segment, and this is a peak appearance site of the twisting by CT, and this is the site peak sign of the twisting by CT. So proximally severely dilated bowel lobe. Cecal volvulus, it must be here. Look for the cecum located in the left upper part of the cavity as a result of the peak sign of the twisting, the site of the twisting. Intussusception, it is invagination of the one segment to the other. Usually occur in the infant, more than 95%, less to be occur in the adult. Ileocolic type is the most common type, and we have colocolic, ileocolic. By enema with the air, reduction can be done during examination. To found patient with the intussusception to the children, you must have a leading cause. The leading cause could be tumor, lymphoma, deepest in the mucosa. By ultrasound, we have sources with mesentery inside. If you look for this, and target sign, pseudokidney sign, crescent, or Indino sign, all of these the feature of the intussusception. Bowel within the bowel. This is a target sign. This is a target sign. Pseudokidney sign produced by ultrasound. By If you look for this filling defect, invagination of one segment to the other, demonstrate the intussusception as occluding mass prolapsing and giving the coil spring appearance. This is a bowel within a bowel. In the bowel. Colorectal tumor, including polyp, is a small mass arising from the wall to the lumen, diagnosed by endoscopy, so by CT. The feature of the malignancy is diameter more than 2 cm of the polyp, short, thick stalk, regular surface. Polyp may be sessile or with the stalk. If you look for this virtual colonoscopy, we have large inside the bowel, and we have a lot of type of the bowel adenomatous, high incidence of the malignancy. If you look for this adenomatous polyp, we have large number of the filling defect indicating polyps. It is a benign with a predisposed to the malignant chance. Should be removed. It may be single or multiple, usually involving the rectosigmoidal region. This is another polyp in this part of the segment. High incidence of the malignancy villus type. Virtual colonoscopy. This is a polyp inside the bowel. This is a polyp, and there are multiple polyps in this segment of the bowel. Occur anywhere in the bowel. Could be occur in the rectosigmoidal region as cecum. So it's different. In the rectum, produce annular structure. Alteration in the bowel habit, so produce obstruction. Patient come to you with small intestinal large bowel obstruction. While in cecum, the mass become large without obstruction because it is away from. So patient come to you with the anemia and weight loss presenting symptom. If you look for this anemia, short segment, usually not more than 6 cm, with shouldering sign, regular of structure, and sometimes the patient produces the fungating mass indicating carcinoma. If you look for this MRI, this is the spine, and this is urinary bladder, and there are well-defined soft tissue hypointense mass indicating the site. And this is the site. And by CT, there is a severely narrow segment of the bowel with the thickened wall, indicating this mass related to the carcinoma. The last slide we have is about Hershey disease. As a result of the absent ganglion, involve the sigmoid rectosigmoidal region. By plain film is the finding primarily those of the bowel obstruction. Contrast the affected segment of the small caliber with the proximal dilatation, transient area between normal and abnormal, fasciculation or sawtooth appearance irregularity. Bowel. You have any question? طلاب؟
لا دكتورة واضحة.
الامتحان مالتكم مالت المد شكوت راح يكون ان شاء الله. اتفقتوا عليه لو بعدكم؟
دكتورة هو الممثل نزل تصويت والطلاب بدا يصوتون،
ايه
ما ادري عاد النتيجة شلون، بس هو على
دكتورة
الاغلب
الخميس
يمكن
يمكن.
الاشعة الخميس، على الاغلب هو الاشعة الخميس.
المحاضرة راح تكون داخلة بالامتحان لكم اياها على الكلاس روم، تقدرون تغادرون حاليا.